Good morning and welcome to Grand Rounds. This morning we are happy to welcome Dr. Shasta Safter. Dr. Safter graduated with her medical degree from Deccan College of Medical Science in India. She did her residency and chief residency at Marshall University in West Virginia. She received her fellowship in gastroenterology and nutrition at Rainbow Baby and Children's in Cleveland. This morning she is going to speak to us on anorectal disorders. Please welcome Dr. Shasta Safter.
So good morning, everybody. I'm going to talk about my favorite topic, anorectal disorders. Usually it's an exit-only zone. So when things don't work in that department, what is the number one symptom that you're going to have? If you have an anorectal disorder, you should have, what's the number one symptom? Residence. Huh? Correct. So constipation is a pretty broad topic, and I'm not going to talk about the bread and butter constipation that you guys see and that you've probably seen in the GI clinic. I'm going to talk a little bit more specifically about anorectal disorders, kind of focusing more at the exit point. And in order for us to understand these disorders, it's important to understand how defecation works, how the exit point works for us. And once we understand that, we'll be having a better understanding of some of the outlet issues that we have in terms of anorectal disorders. We'll talk a little bit about some of the congenital anorectal malformations, because that is sometimes commonly seen, misdiagnosed, and not appropriately managed in pediatrics. And we'll understand what kind of diagnostic and therapeutic tools that we have for management. So as I said, the number one symptom is going to be constipation. But again, let's kind of talk about defecation, which is the act of actually emptying the colonic contents. So remember, defecation is a coordinated process. It involves generation of propulsive forces in the abdomen and in the rectum, along with relaxation of your pelvic floor. So what constitutes your pelvic floor? The puborectalis muscle and your sphincters, along with the levator ani, that is your pelvic floor. So while you're generating propulsive forces within your abdomen and your rectum, you have to relax the pelvic floor in order for defecation to occur. And likewise, continence, not soiling on oneself, right? That involves the sphincters to be intact. Elimination should be voluntary, right? If you have lost control over your bowel patterns, then you're considered fecally incontinent. So again, the sphincter complex and the pelvic floor have to be intact in order for you to have control over your bowel patterns. And if you have a failure of this process, you're going to have a problem. And that's some of the things that we're going to cover in today's discussion. So this is a good visual of what is happening. When somebody's holding their stool, you can see here the pelvic floor, the puborectalis. This is the puborectalis muscle. It's contracted, and both the sphincters are contracted. When you initiate defecation, the abdominal muscles are being pushed down. The external anal sphincter will start to relax along with your puborectalis, and your levator ani starts to rise up. So when all of this happens, your pelvic floor will actually descend down. And then when you completely expel stool, both the sphincters are fully relaxed, the rectum is squeezing, the puborectalis is completely relaxed, and you have a pelvic floor that has descended. So again, if you understand how this works, then you'll understand why things don't work. Another important thing is the anorectal angle. So this is the angle which is at rest. But when it's time to defecate, when the pelvic floor descends down, the anorectal angle increases, right? And this is also important in emptying the rectum completely. If you cannot descend your pelvic floor, this angle will remain and you will have incomplete emptying. Which brings us to this multi-million-dollar invention of the Squatty Potty. So the correct physiological position for good pelvic descent and complete emptying should be the squatting position. So when somebody is squatting, like you see here, that automatically increases the anorectal angle, and it will help the pelvic floor descend and actually helps the sphincters relax more completely. So again, when we're trying to do education in our clinic with children who might be suffering from some sort of outlet issue, we definitely talk about positioning. And so sitting on a throne, like we do, is not conducive to a good anorectal angle or for pelvic descent. But again, in the squatting position, we'll be able to get what we desire. So getting this little stool is actually useful and helpful. And if you can't buy the stool, just explaining, having the legs propped up, knees bent, knees separated, again, trying to create that angle will help a child who's probably struggling with outlet dysfunction. So a little bit of just a review of what our sphincter complex looks like. Remember, there are two sphincters, the internal anal sphincter, which is actually smooth muscle. So it is not under volitional control. It is part of your enteric nervous system, and it works off of a reflex. The external anal sphincter is what we control. So when we're holding it until we make it to the bathroom, we're controlling our external anal sphincter, which is actually skeletal muscle. And again, this is important because when we talk about how we test for these patients, we're going to look at a reflex that uses your internal anal sphincter. So again, to review how we poop, we initiate defecation, either because we voluntarily start to squeeze our abdomen, either because there's a gastrocolic reflex, which means in response to a full stomach, it sends a signal to our colon to start contracting. It's a colonic reflex, there's distension in the colon, there's some direct irritation to the rectal mucosa. This is the principle on which stimulant laxatives work, right? Like bisacodyl is an irritant laxative. It's a stimulant laxative because it irritates the mucosa, sets up contractions or rectal distension. So that's how the reflex is initiated. The rectum will fill, will distend, there's increased pressure, and this leads to stimulation of the pelvic floor and the desire to defecate, right? So when you feel you gotta go, that's your internal anal sphincter starting to relax, okay? Now, whether you go or not is when the external ones, right? So if it's appropriate, you made it to the bathroom, then you relax your external anal sphincter and complete defecation will occur. But if there's not the right opportunity, then you will probably keep your external in a contracted pattern, even though your internal is reacting, even though that desire is there. And what happens is if you do that enough times, you will get rectal adaptation, which basically means you're holding it and your rectum starts to stretch and accommodate holding larger and larger amounts of stool. So again, this is a nice visual which explains the physiology of defecation. So again, this is our mechanical barrier, the puborectalis internal and external anal sphincter. And during normal defecation, the rectum distends. There is, again, abdominal contraction. The sphincters will relax. The puborectalis will relax, which will allow for defecation. In incontinence, it's different. In incontinence, there may be issues with the puborectalis at rest, at baseline. Maybe you don't have a good, pelvic floor. There's a problem with the sphincters at rest. I'm talking more about non-retentive soiling, and we'll talk at length the difference between retentive and non-retentive soiling. But in these patients, there might be also a neuropathy or some sort of nerve damage that is causing this incontinence and this weakness almost in this pelvic floor. Versus dysonergic defecation, which is a lot of what we see in pediatrics, where you have a patient with poor transit, rectal hyposensitivity. This is a patient in whom rectal adaptation has occurred. Their rectum is really, really stretched out. They can really pack in a lot of stool without feeling it, right? So they're hyposensitive to that distension. And their sphincters will not relax, even though they are trying to voluntarily push their abdominal muscles and evacuate. There is poor sphincter relaxation. Less than 20% of the sphincters are relaxing, and they can't really push it out, right? So this abnormal, paradoxical contraction of the pelvic floor when you're trying to defecate is known as fecal dyssynergia, and we'll talk a little bit more about that. So typically what we see, the bread and butter constipation that we see in our clinic is usually the functional constipation. It starts off with hard, painful stools that become difficult to evacuate. And when they become difficult to evacuate, the child develops withholding behavior. And this is how we understand soiling in the classic sense, where you have overflow soiling of liquid stool contents around hard stool, and you have a child who's encopretic. When we talk about the types of constipation or why constipation occurs, there's 3 subtypes. It could be a slow transit issue, so the whole colon is slow, the whole colon is sluggish. It takes very long for a stool to even move through the length of the colon. Or it could be an outlet issue with dysenergic defecation, right? So the stool makes it, but it's sort of all accumulating at the exit point. It's like how I felt on I-4, all 4 lanes, one exit point and nothing's moving. So that's how dysenergic defecation works. It's an outlet issue, and patients who have dysenergia cannot completely evacuate. They have excessive straining, bloating, and blockage. And always remember, when you're dealing with somebody with constipation, rule out the secondary organic causes: hypercalcemia, electrolyte abnormalities, thyroid problems, celiac disease. Look at their medications, because all of those could be contributing factors. This we all know. If you have somebody with constipation, they have less than 3 bowel movements a week. They're hard, dry, difficult to pass bowel movements associated with pain and nausea, and the classic overflow soiling or retentive soiling, which is a clogged rectum and liquid stool leaking around it. And remember, when you have a toddler who develops these kind of symptoms, and they've repeatedly experienced pain or dyschezia with defecation, they have a lot of withholding behavior. That reflex that I'm talking about, right, over time it becomes almost automatically. They will keep their external sphincter contracted, and that is what withholding behavior is. And the more they do that, the bigger the stool burden, the harder the stool mass, the more painful the defecation. So it turns into a vicious cycle. And from a general pediatric standpoint, understand and recognize the symptoms of withholding. So when you have a child who's crossing his or her legs, clenching their buttocks when it comes time to defecation, hiding in the corner, turning red, making faces, their parents are like, they're trying to poop and they can't. And the answer is no. They need to poop and they won't, right? It's not that they're trying to poop and they can't. That is withholding. They're going red in the face and walking on their toes because they don't want to do it, right? So at that point, you really need to alleviate the pain and the discomfort, and that's where you have to intervene with, stool softeners or laxatives and toileting position, right? Because if it hurts a certain way, if they're not able to relax their pelvic floor, then they won't be able to completely expulse the stools. So don't be afraid. Please don't be afraid to do a physical exam. And my topic is anorectal disorders, so you can't get away without doing a rectal exam, right? And my only advice to residents is, if you've never done a rectal exam, and you have that one kid, and that's the first time you're doing a rectal exam, you're not really going to know. If you don't know what normal is, you're not going to know when you feel abnormal. That's my point. So I'm not saying every kid in your clinic deserves a rectal exam, but you have a kid who's soiling, who has severe withholding behavior, who is just not responding. Look at their perianal area. Look for the anocutaneous reflex. Anybody know what the anocutaneous reflex is? The anal wake, right? So you do the little scratch at the perianal area, and the external anal sphincter will contract. So that it's a reflex arc. The anal wink is a reflex arc. So it's the pudendal nerve that carries it to S2, S3, and it's a reflex arc. So if you have any sort of injury to the reflex arc because of a spinal cord injury or what have you, you won't have a wink, an anal wink, right? So that would be your clue that something else is going on. Especially, I think, what I want you guys to recognize is the difference between retentive and non-retentive soiling, right? And so how are you going to know? So if you do a rectal exam and you feel a very dilated rectal vault and you feel like a fecal impaction, then obviously you're dealing with a retentive soiling issue, right? Sometimes you have patients you've put on Miralax or laxatives, and the parents come back to you and they've stopped all medications because it made them have diarrhea. What did that mean? That made their encopresis 10 times worse, right? And they stopped the medication. And sometimes, unless you've done a rectal exam, you're not going to know this, right? The other thing is not just to assess the rectum and whether they're impacted or not, it's also to assess the pelvic floor. This whole topic is about anorectal disorders. So if you don't have a fancy anorectal manometry or GI person to help you out, doing a rectal exam can give you an idea about what their pelvic floor is doing, right? Remember, when you have a patient do a voluntary squeeze, you can have the finger and you can be like, squeeze against my finger, make it tight. You are checking their sphincter tone when you ask them to do that, right? When you ask them to push and explain to them, look, I'm trying for you to like have a bowel movement, like push with your abdomen and try to relax your muscle, like try to push my finger out. And if they can't do that, they may have an element of dyssynergia. Do you understand what I'm saying? So you can get a lot of information by doing a rectal exam. If you have a patient with neurogenic bowel, if you have a patient with spina bifida, if you have a patient with a spinal cord injury, their sphincters are typically incompetent. So you do a rectal exam, before you start a rectal exam, you'll see a sphincter that is lax, open, and loose, with a lot of soiling. And if you don't wipe off the soiling, you won't even be able to visualize the sphincter. And sometimes you try to attempt an anal wink, and you just see a sphincter that just relaxes like that, right? Which is so abnormal. So again, if you don't look, you won't know. So get comfortable with doing rectal exams. Get comfortable with looking at the perianal area. And when I talk about anorectal malformations like an imperforate anus, which is typically everybody in Gen Peds, newborn baby in the nursery, if you miss it there, you know, that's not good. And if you've never seen it, and if you don't know what normal is from abnormal, you're going to miss it. And remember, if you have an imperforate anus, it doesn't mean that there's nothing there. Most patients with imperforate anus will have a fistula, right? They will have either a rectocutaneous fistula, a rectovaginal fistula, a rectovesicular fistula, and sometimes that fistula will be leaking stool. So the baby would have, quote unquote, pars meconium. Do you see what I'm saying? So you have to be in the habit of looking, understanding, and definitely knowing normal from abnormal, right? When you have a baby with an imperforate anus, there's no sphincter tone complex. It's almost like a blind track that ends on the skin and it's leaking stool, okay? We'll go over some pictures of imperforate anus. All right, so this we covered: constipation, painful, withholding, soiling, makes the family mad, and there's a lot of education that goes into play because, you know, this is a learned behavior. A toddler is not doing this to, you know, exercise control over the parents. It becomes a learned behavior. It's painful, and unless you address it with the family, it becomes a little bit of a, you know, battle of the wills. We covered this. These are the typical signs of a fecal impaction. The kid might have abdominal pain, large stool palpable masses in the lower abdomen, retentive posturing. Why does this occur? Why does withholding behavior occur? Why do stooling difficulties occur? Well, changes in the diet, early toilet training, medications, change in routine when they travel, they get dehydrated. So lots of reasons. Remember kids who drink 52 ounces of whole milk a day, which of course we recommend. No, I'm just kidding. You know, the casein and the whey, you know, that's constipating, but that's really our patient population, and really there are, of course, other real organic causes that we should be screening for. And once again, anatomical malformations, so looking for anal stenosis. So you may not have an imperforate anus or a fistula, but you may have anal stenosis, which again could be parts of a Curiano's triad, right? So again, a rectal exam is very important to help you cue into that. As I said, you know, screen for other issues like celiac disease, electrolyte abnormalities. CF is a big one, right? Because you will have patients who might have a meconium ileus at birth and struggle with constipation throughout their life. Spinal cord injuries, like we talked about, and intestinal nerve disorders. Hirschsprung's disease is probably the kind of most classic hallmark thing that we definitely don't want to miss in any patient. And any form of, you know, visceral myopathy, neuropathy could be a potential issue that causes anorectal disorders. So I'm not going to go into all of the functional constipation categories, but just one little blurb about infant dyschezia. Again, something that you all see in practice every day. Infant dyschezia is a baby, a normal baby, who is going red in the face while they're trying to poop, right? I mean, this baby could be breastfed, normal, thriving baby, but they seem like they're squirming and they seem like they're crying for 10 minutes when they're trying to have a poop. And the mom tells you, my baby is constipated, right? And you get a little bit more of the history, and the baby is actually passing soft poops couple of times a day, but every time it's time to poop, the baby's going red and squirming and is crying and seems uncomfortable. And that is a real phenomena called infant dyschezia. And basically, it's a little bit of a maturational issue. The baby is not relaxing their pelvic floor all the way, and they cry, they tense their abdomen, so they generate all the propulsive forces up here, but with their butt cheeks, they're clenched. and they're just crying and they're probably stiffening out or whatnot. And it's because they haven't learned that you actually got to relax the butt while you're pushing down. And so sometimes, just helping the baby, exercising, putting them in that kind of, bicycling position, if you will, might help them. But this is something that most babies will overcome. So the key thing here is this is soft stool. They're having regular stools. They're just getting uncomfortable. And if the parents watch how the baby is stooling, and if you get an opportunity to watch, you'll probably pick up on the fact that they may be having some infant dysphagia. And this is something that it's a functional issue, and it will get better with age. Again, the 3 common times where we see issues, stooling difficulties, when you first introduce solids to a baby. The second time is when they're toilet training, and the third time is when they start school, because these are all kind of, major changes in their life or developmental milestones. And sometimes if stool caliber consistency changes and it makes it hard and difficult, then that's when the problems will start. So again, it's important to know what normal stooling is, right? And it's different for different ages and stages. So in the first week of life, a baby will poop up to 4 times a day. In the first 3 months of life, you may have a baby that poops up to 3 times a day. Formula-fed babies a little bit less. By the time they're about 2 years old, they have an average of about 2 poops a day. By the time they're 4 and up, they're usually stooling 1 time a day. We all know that breastfed babies can either poop many times a day or can go 7 to 10 days without pooping, right? All within the realm of normal. So again, it's important to know what's normal so you identify what's abnormal. Do remember that the type of formula that the baby receives will affect stool caliber and consistency. So obviously, soy-based formulas make the stools harder. Hydrolyzed formulas, your peptide-based formulas will make the stools a little bit looser. So when you put a baby on Alimentum and mom says, my baby's having diarrhea, right? That's normal. That's normal because peptide-based stools look dark green, green and runny, and that's because of the type of food that they're receiving, right? This is a good slide. Colonic transit time. So this is the time that it takes for the stool to move through the entire GI tract. So remember, for a baby, 8 hours. They're really short-gutted. They eat, they poop, they eat, they poop, they eat, they poop. You change diapers all day long, right? Because they're short-gutted. They have a quick transit time. As they get older, that transit time will decrease. By the time they're getting to about, early childhood, their patterns are mimicking more like our patterns. It's like once a day you poop, and that's normal. But it can, for some people, up to 48 hours, and that could be still considered normal. So that's why our threshold is an average of 3 poops a week. So there's some people, some older people may not be everyday kind of people, but they may poop 3 times a week, and it doesn't hurt, and it's easy to pass, and they don't have any issues, and that's all good. That's just their transit time. The concept of anismus is painful defecation. So just a word about patients who develop tears or anal fissures. Remember, anal tears and anal fissures specifically. So tears are more superficial, fissures are a little bit more deeper, probably nerve endings are exposed. That is very, very painful. It literally feels when the poop is coming out of their butt that something is cutting them with a knife. Okay, so who would want to poop in that situation, especially if you're a child who doesn't even understand what's happening? So understand that anismus is just like almost a reflex contraction because it hurts, and be good about looking. Again, if you don't do a rectal exam, you're going to miss the tear. You're going to miss, unless you really separate and look, you might miss the tear or the fissure. And treat. If it looks terrible, if it's bleeding actively, if it looks raw and irritated, if there's a severe perianal rash, let's just say that, they went through like a GI bug and now their entire butt is like, burnt because they were having acidic stools, they're not going to want to poop, right? Because it hurts, it stings. So address those issues, treat if there's any perianal issues to prevent things like anismus. The only motor abnormality that typically occurs in a severely constipated child is lack of rectal strength, because remember, the rectum has to contract to push down, right? But if the rectum is so dilated because it's been impacted with stool, the motor effect of this very dilated lumen is very weak. Okay, so if it was more of a normal colonic lumen, it would contract effectively, but when it's this dilated, the motor effects are dampened. So this brings us to one of our diagnostic tools, which is anorectal manometry. This is helpful for us to really understand what might be going on in terms of an anorectal disorder. An anorectal manometry is a catheter that contains pressure transducers. So this is the balloon that is within the rectum space, and within the catheter lumen you have pressure transducers that you try to place within the sphincter complex. And essentially, you measure anorectal function in different ways. So you want to understand how the sphincters work, so you want to get a baseline of what the sphincter pressure is at rest. You want to check for a very, very important reflex, the RARE, the recto-anal inhibitory reflex, okay? What the recto-anal inhibitory reflex is, it is a reflex relaxation of your internal anal sphincter in response to rectal stretch. So what we do is with the balloon, we stimulate, we increase the balloon, so we stretch the walls of the rectum, and the internal anal sphincter should relax on a reflex. So when you feel like you got go, right, when you're like, oh, I should find a bathroom, there is rectal distension that has occurred in your body, and that internal sphincter is starting to relax, which is your sign you gotta go. But remember, you control it with your external anal sphincter until you make it to the bathroom, and then when you decide, you relax your external anal sphincter, and that's when evacuation happens, right? So because the RARE uses only the reflex of the internal anal sphincter, what did I say? The internal anal sphincter is smooth muscle, and it's under enteric nervous system control. So you don't control it, right? So if your enteric nervous system is disrupted for whatever reason, you're not going to see a RARE. And the number one reason why you would have a disrupted enteric nervous system is because you don't have nerve cells there. You don't have ganglion cells there, right? So what is that diagnosis? Hirschsprung's disease. So if you have a patient where you don't see this reflex, you're going to be worried about Hirschsprung's disease, okay? So this is a good tool that sometimes will save us from doing a full thickness rectal biopsy in a patient or a baby who may be having stooling difficulties. There are other things that we can test beyond the reflex and the sphincter pressure. We can understand the defecation dynamics. We can ask the patient to squeeze and really measure how much sphincter pressure they can generate. And again, if they have a nerve injury, if they have a neuropathy, they can't do that. We can understand their push effort. We can evaluate for dyssynergia, because when we have them push and their sphincter is not relaxing, that's dyssynergia. And the last thing we do is balloon expulsion, which with a small inflated 20 or 30 ml balloon, we actually have them sit on the toilet and we're like, just try to push it out. Most kids can't when they're dyssynergic, right? So there's a lot that you can understand by doing anorectal manometry. I like this slide because it's a good visual of what a RARE is. So just to make it simple, we just have two pressures that we're showing. This is the rectal pressure, right? So we are distending the rectum because we're putting air, or let's say there's poop or what have you, right? But the rectal pressure increases, and the sphincter, the anal canal, which contains the sphincter, the pressure decreases. So this is the reflex relaxation of the sphincter in response to rectal distension. Okay? Again, if you don't see it, you're going to be worried about Hirschsprung's disease. Okay? So again, am I clear about what a RARE is? R-A-I-R. So a lot of our reports will talk about a RARE. You're wondering what a RARE is. That's what a RARE is. Okay?
That's the internal.
Internal. Correct. So when you have Hirschsprung's disease, it's basically you have an aganglionic segment, right? So it doesn't have the nerve cells, it doesn't have a RARE, it doesn't have nerve function, it doesn't have function, period. Okay, so it's like kind of the poop gets stuck there. There's no help, there's nothing that happens in the aganglionic segment. So that always has to get surgically corrected. These are different surgical techniques to correct it. All of them have pretty much lost favor. The only one that we see right now is the Suave endorectal pull-through procedure, where they do a resection of the aganglionic segment, either in a one-step or two-step procedure. If it's a long segment, you might have a child with a proximal colostomy, but later on we'll have an endorectal pull-through, meaning they try to pull the ganglionic segment all the way up to the anal canal, right? And that's how they correct this problem. A lot of patients with Hirschsprung disease, we see patients, they're admitted to the floor, they have issues. They have issues because sometimes at the anastomosis, there are problems with the sphincter. You will have the surgeons having these kids getting rectal dilations, right, for a period of time, because they do have issues with their sphincter. They are prone to develop enterocolitis, and sometimes, despite the surgeon's best effort and doing intraoperative sampling of ganglion cells and thinking that what they've anastomosed has ganglion cells, there might still be an element of dysmotility in the segment that they connected, right? So sometimes, I think we see a lot of Hirschsprung's kids who've had a good repair, they're out in the community, we never see them, they're on cruise control. We see the ones that have had problems, the ones that keep coming back to the hospital over and over again, definitely are the ones who, who probably did not have a great success with their surgery. Also, another word about patients with Hirschsprung disease, they struggle with sphincter issues, they struggle with constipation issues, and they can struggle with the other end, which is soiling. And again, the knee jerk is, oh, it's constipation soiling, let's just keep their stools more runny. But if you have a significant portion of your sigmoid colon that was resected, you no longer have a reservoir, right? Because your sigmoid colon is where you hold the stool. So if that's missing, and let's say they took out the last third of their colon, it's kind of like a straight shot from your transverse colon to your anal opening, right? And so these kids might have such a quick transit that they might be soiling for the opposite reasons, right? And so actually slowing down their motility may help. But again, this is probably where you should get some testing and understanding and not just go knee-jerk by the only symptom that they're presenting. And I think it's important to probably study a kid who's had complication post-Hirschsprung to understand what exactly is going on, because anything could be going wrong. So we covered dysenergic defecation. Anorectal manometry is probably the best way to diagnose dysenergic defecation because you can actually measure the pressures. And because you have a sensor in the rectum and a sensor in the sphincter, you can see what the rectum is doing and what the sphincter is doing. Some patients will have just a problem with the sphincter not relaxing despite good effort in the abdomen and good rectal pressure. Some patients may just have no pressure, like they're not even exerting pressure in the rectum and not relaxing. Some of them push but don't relax completely, so that's how you kind of classify the different types of dysenergic defecation, and this is what it would look like. So again, here we have normal, so you have somebody who is, this is happening voluntarily, by the way. They're exerting pressure in the rectum and their anal canal is relaxing when it's time to push out, defecate. In dysenergia, they're generating that abdominal pressure, but what's happening here? Is it relaxing? No, it's squeezing, right? So this is what fecal dysenergia is. Does that make sense?
Does that include infantile?
Well, this is happening in infant dyschezia as well, but they get better with it. I think the problem with older kids versus infants is they do start to retain hard stool. And then it becomes more harder. In an infant, I think it's soft stool. It's just that they haven't mastered how to relax their pelvic floor. But in the older kid, it becomes habit. And it becomes like almost reflex and instinct. When they feel rectal stretch, they naturally start to tense rather than to relax. And I think that behavior has to be unlearned. And how do we do that? That's an excellent question, is we can do things like biofeedback therapy. So we'll talk a little bit about biofeedback therapy. Here's another good visual. I like how they show the sphincter is definitely augmented when you have dysenergic defecation, and the sphincter is definitely lax or loose when you have issues with incontinence. So that brings us to biofeedback therapy. Biofeedback therapy is a way where you can give feedback to a patient with using the sensors, using the catheters as a visual guide, and show them what they're doing with their muscles and train them if they're old enough to be trained, that is, right? I mean, you can't really do it in a toddler who is not going to listen to you with something up his butt, but you could potentially retrain them to understand how to use, their sphincters better. The other thing we can also improve when we do biofeedback therapy is help them understand rectal sensation. So there's sensation, and then there's urge, and then there's maximum tolerable volume. So with that balloon that we have, right? So we can inflate the balloon and we're like, can you feel it, can you feel it, can you feel it? And most of the kids are like, yeah. I was like, so you say you're feeling it, but would you go to the bathroom? And they're like, no. I said, why? And they're like, yeah, because it's not strong enough. So what most kids are waiting for is urge, where it's like this, and you can't hold it. And the sphincter is like, the internal sphincter is like this, like completely relaxed. It's like, go to the bathroom, right? But that is what withholders are. They're so busy with their computer game or their TV show or what have you, they will ignore sensation, right? So they wait until they have urgency, and sometimes it's just amazing because we can keep going up on the balloon, like, can you feel it, can you feel it, can you feel it, can you feel it? Like, no, 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 no. And you're like at 200 cc's and you're like, what is going on here? But that is what happens, and that's rectal adaptation, and the body can stretch and change. But what I found is a really useful tool when I'm doing biofeedback therapy with the kids is when I'm working on sensation, and every time they come back, I work on that. And let's say a normal kid should feel it at about 30 to 40 ml balloon volume, which is about that much, a normal kid. But these kids don't feel it until much further. And again, it's because they've been ignoring that sensation. And I was like, listen, remember this feeling. When you feel like this, even though you wouldn't stop your video game and go to the bathroom, you need to go to the bathroom, right? So it's that repetitive training sometimes that will eventually click. So this is what it would look like. If you did a biofeedback training session, remember, this is the rectal pressure and the anal pressure. So this is at the starting point. This patient is not trying, not exerting any rectal pressure, and definitely having a lot of squeezing in their sphincter. Here they're starting to use their abs a little bit, but really not doing the right thing with the sphincter. They're still squeezing, but eventually they'll get there where they're generating rectal pressure, relaxing the sphincter tone, and that will help with evacuation. So just a word about defecography. We don't use this commonly, and honestly, we shouldn't use this commonly. We should probably reserve this for if we're worried about a rectal prolapse, some sort of perineal descent. It probably has more applicability in the adult populations. You've had women who've had, obstetric injury, grade 4 tears and whatnot, and they really have issues with their entire pelvic floor. They're having bowel incontinence, bladder incontinence. So a defecography, especially a dynamic MRI, might be helpful and useful. It's good in evaluating rectoceles, rectal prolapse, but again, it's not something I would want you to even order at your level unless there was, a very good indication. But it is a tool that we have in our available to us to understand anorectal malfunction, which brings us to our next testing is motility testing. So I remember I said there's problems with transit and there's problems at the outlet, right? So motility testing can definitely give us an idea if it's a transit problem. And to be honest with you, if you have fecal dyssynergia, over time, you may have had slow transit and that allowed you to accumulate it in stool and get dyssynergic, or you may have a normal transit and you may just have issues at the outlet. So again, doing motility testing to understand the transit time of the colon, which we talked about, is helpful. This is an easy test for anybody to do or order. It's a SITS marker test, and basically it's a transit study. You give them a capsule with radiopaque markers. They swallow the capsule and they get x-rays. Every institution has their own, protocol. We typically here at APH do an X-ray on the 3rd day and the 5th day, and then depending on the distribution of the markers. So at day 5, if you have something like this, the markers all over the place, 5 days later, that's an issue with transit. If you have something like this where all the markers sort of got to the exit point and just sort of sat there at the exit point, it's probably more of an outlet problem, right? So it definitely gives you an idea. Typically, if more than 20% of the markers are retained at the end of the study, something is wrong, and it is helpful in understanding why the constipation, if it's transit versus just outlet. This is something that is being used in some of the quaternary centers, and it is approved for over 18, not under 18. But again, it's another easy way of doing a transit study. It's called a SMART pill, and it's really smart because it can do 3 things. It can measure temperature, it can measure pH, and it can measure manometric contractions. And so you basically swallow that one little pill that you can see there, right? And you wear this little, it looks like kind of like a CD player. Oh my God, I'm dating myself. A CD player, an iPod, excuse me. So you just wear that around, and it wirelessly will transmit signals. And so when you get the study, this is kind of what it looks like. So again, when something leaves the stomach and enters the bowel because the pH changes. It goes from acidic, right? The pH rises. The red is basically the contraction pattern. And how do you know it exited the body? Because it has this temperature sensor. And so when you poop it out at the end of the day, the temperature drops when it hits the commode. So it basically is a way, because you can measure this time from ingestion to exit, so it gives you a transit time. It doesn't give you a lot of details of the quality of contractions or whatnot. It's hard to read, but definitely it's a transit study that we have now available for us. And then, of course, what I do, which is colonic manometry. This is where you place a colonic motility catheter and you can measure the entire length of the colon, and you can understand segmental activity and propagative activity. And of course, this is kind of what it looks like. This is a colonic motility catheter. It's got sensors, and we will, basically measure the entire entire length of the colon to see if there's a problem with propagation. And again, this gives us a good understanding of, transit issues versus outlet issues. So what do we do about all of these patients? How am I for time? I don't have my phone on me. Am I okay? Okay. All right. So use the Bristol stool chart. I love the Bristol stool chart because, instead of asking them, do your poops look like chicken nuggets, mashed potatoes, scrambled eggs, applesauce, you can show them the Bristol stool chart and be like, where would you say your poop is, right? Our goal is 3 to 4, nice, smooth, long, less cracks, not pellet-like, and obviously if it's going too flaky or turning into mud or sand, that's a problem too. So remember to use this to guide your treatment and therapy. You can always use osmotic laxatives and stimulant laxatives and the newer pharmacological agents, but just use the stool to guide your management. And in terms of surgical intervention, so we talked a lot about sphincters, and we talked a lot about Hirschsprung disease complications, and we talked about outlet dysfunction. There are some surgical techniques, myomectomies, which is invasive, and definitely you need to really know why you're doing a myomectomy and not create more problems for yourself. Botox injections is getting popular, but just remember, we are injecting Botox, which is a poison, into somebody's body, and there are certain risks and side effects that you have to know of, but it will help relaxation of the sphincter. And then we are going to talk a little bit about the management using cecostomies, an ACE procedure, an anterograde cecostomy versus a retrograde enema and other surgical interventions. So we'll touch about that in the last few minutes. Who's ready for Christmas? Raise up hands. Good. I shop on Amazon, so it's the only way to shop now. So every time the UPS guy comes, it makes me happy. And I thought of this diagram about, how, the UPS guy and delivery makes you happy, but people who are constipated and UPS are both happy to see brown. Oh my God, you guys are sleeping. You're not getting it. Get it? You're happy to see brown. Whatever. Okay. So the other end of the spectrum, fecal incontinence, right? So we just talked a lot about constipation, withholding, hard stool, and then soiling around it, right? But remember, fecal incontinence can also be non-retentive, meaning you don't have a lot of stool retention in there. In fact, you may have no stool retention in there, but there may be something wrong with your sphincter complex. Your sphincter is disrupted for whatever reason. You have a fissure, you have pain in the sphincter area, and you will have either urge incontinence or stress incontinence. And it's important to understand what the nerve innervation is to understand what may be going on. So again, remember the colon is receiving both sympathetic and parasympathetic inputs, but when you specifically look at the thoracolumbar-sacral area and what kind of input, we're getting the pelvic splanchnic nerves, the pudendal nerve, the sacral root branches. Any disruption in the lumbosacral area is going to affect your bowel, correct? I mean, once you look at this diagram, you understand how. So the number one thing from a pediatric standpoint, or the number one disease process that we need to know about is spina bifida, right? Because we all know this is a permanent disabling condition. It literally means a split spine when the spinal cord doesn't close all the way. And 1 in 8 babies, 8 babies every day are born with spina bifida in the U.S. So it's definitely a common problem. It's an increasing problem, and you need to understand bowel and bladder management with these patients because of their congenital anomaly. They have neurogenic bowel and neurogenic bladder, both. Okay, so they're going to have issues with continence, both urinary and stool, and it's important to know how to manage them. The worst form of spina bifida is obviously a myelingomeningocele because there's not just the herniation of the meninges, but also part of the spinal cord. And again, you worry about lower limb, motor deficits, as I said, bowel and bladder function, and even cognitive function in these kids. So 2 things that happen in neurogenic bowel, your colonic transit time will be increased, right? So they have constipation, but they also have incontinence because their sphincter complex is completely relaxed or incompetent or low tone, right? Because again, the lumbosacral area nerve roots, it's disrupted. I mean, it never developed and it's damaged. And so they will have a lot of incontinence even when they may not have a lot of significant stooling. So they have issues with control. So the only way, and because of the disruption in the nerve supply, they don't have good sensation. So another patient population where you can keep going up and up and up and on the balloon and you're like, nothing, is a patient with spina bifida. They can't feel it. You could do a rectal exam, they can't feel it. I have done enough rectal exams to know they don't know if my finger is in or out, right? So they have severe rectal hyposensation. They lack the reflexes. They have a poor sphincter tone. And when it comes to quality of life, right? When I went to the Spina Bifida conference, there were two things that determined if these patients were able to function independently as members of society. And it was school, obviously, you know, those who went to school got an education, and stool. I mean, having bowel continence was such a quality of life measure for most of these patients, because if they were in a diaper in their adult life, they were not going to go out and seek a job. They smell, they're basically homebound. And so having bowel continence cannot be underestimated. So how do we achieve bowel continence in somebody who has something that you can't fix with manometry, biofeedback, nothing? You can't do anything about this, right? This is a congenital problem. So you have to put them on a bowel protocol. And there's a couple of ways of doing this. So you can do this method, which is retrograde irrigations. So typically if you did an enema, this is how much you would get out. This is how much you would clean out. But when you do more of an anal irrigation that a lot of our spina bifida patients do, the thought process is you give them a retrograde flush that kind of cleans out the distal third of their colon, right? The most important part, which would have the most stool burden or stool loading. And so now we have different ways of doing this, one of which, this is a little bit more old school, is called a cone enema. And as the name suggests, there's this cone. Why does it look like a cone? Because of their sphincter complex. It's lax, it's open, so the cone can go in comfortably, create a seal, and then basically you just kind of infuse water, and sometimes you can add things to the flush, you know, shampoo or Miralax or what have you, and it will go into the distal third of their colon. You have to kind of have a retention time for a few minutes, remove the cone, and then sit. The problem is it's not very user-friendly. You need somebody to hold the cone in place, right, because it's going to slip out. So now, in the last few years, we've received this medical device called the Perinatal anal irrigation system, which really has improved the quality of life, because this catheter can be easily inserted by the child. And how does it hold in place? You're like, well, you said it's like this, so the catheter's just going to slip out. Well, the beauty of this device is that it has two knobs, and one of which controls a balloon, and that balloon will actually hold the catheter in place. Then you turn the nozzle to the water, and it's basically, you can flush the colon out. And I like, it doesn't matter, it doesn't require a lot of dexterity. You can strap this to your thigh. So one of the things I do in my clinic is when I have these patients come in, I will train, if the child is old enough and has enough dexterity to hold, and they are independent with their bowel protocol. They can do this by themselves independently. And it has been a game changer. It works, in my opinion, better and more effectively than the cone, and improves their quality of life. So this is a study that showed scintigraphy before and after defecation. So the bright areas are the areas that had fecal loading before transanal irrigation. And you see here the descending colon and the rectum completely empties out after you do a rectal irrigation. So if you basically do this every night, you get it all out of your system at night, kind of like on a scheduled basis, there's nothing there to leak out. There's nothing there to have an accident, right? When you have an accident, it's because something is leaking out when you least expect it. And again, they can't control it. So if you do this irrigation on a nightly basis or every other night and some sort of regimen, they do get continent. They don't have to worry about diapers. So it is important. So we talked about the retrograde approach. An anterograde approach is a cecostomy. You see a lot of our patients sometimes will have constipation, will have cecostomy, spina bifida patients. So this slide I just put there for you guys to understand what cecostomy tubes would look like. Sometimes you can have a regular Mickey button put in the right lower quadrant to function as a cecostomy, but sometimes you'll see this. This is called a shade trap door. This is not something that you can just replace, and it's also something that Central Supplies doesn't always have, but we upstairs in the GI office have this, and we can change it out. This is what a cecostomy looks like on the inside. A shade trap door. It has a little pigtail that holds the tube in place, and it's a little bit cosmetically pleasing because it sits flush against the skin and you can't really see it through clothing and so on and so forth. But the concept is the same. Whether it's a Mickey button, whether it's a mace, which is what the surgeons will do, which is a continent valve, or whether it's a cecostomy, the concept is you will flush the colon from the cecum all the way down. So your flush volumes might be a little bit harder. It has to travel. I feel like it's helpful to do a manometry before determining who would be a good candidate to understand a little bit about their transit time. Because if you have somebody with an inherent dysmotility and very poor transits, even with a flush, their colon just tends to stretch out like this rather than just push the flush forward. So it's not always a slam dunk, but these are definitely ways that we can alleviate some of the issues. This is what an example of an imperforate anus. So switching gears a little bit, remember the voctral anomalies are the ones that you're going to see imperforate anus with. This is what it looks like. So this is a little fistula, right? That looks like it's draining stool, but essentially it's an imperforate anus. And remember, you can have a high defect, or you can have an intermediate defect, or you can have a low defect, depending on where the atretic segment begins and whether there's a fistulous tract. So typically, the more higher the imperforate anus, the more severe the anatomical issues, the more the chance of rectovaginal or rectovesicular fistulas. This is a good diagram of just kind of showing you this is what a normal opening should look like. Here you have an opening that just really didn't make it to the pelvic floor. Here you have an opening in the wrong place. Here you have it turning into a fistulous tract. And when you have a cloacal abnormality, all three openings, vagina, bladder, colon, everything sort of coming out through the same opening, right? So that is a cloacal malformation, and it is quite a surgical, task to repair and put all of those organs back in the same place. So typically when you have somebody who's had an anorectal malformation or an imperforate anus, remember this part is missing. So the initial first step is probably a diverting colostomy with a distal mucous fistula. And at some point when the child is old enough, then they might undergo a posterior sagittal anorectoplasty and repair. Now I see a lot of kids status post-repair. A lot of issues with incontinence, a lot of issues with defecation, a lot of issues with sensation. So again, these patients, even though they've been put back together, a neo-anus has been created, right? They created a passage and now it connects to the rectum. Just because it's sort of all put back together and lumen has been established doesn't necessarily mean it's all the way functional. So there is a lot of disruption of the sphincter complex in the pelvic floor. These repairs are very extensive, and so these patients will also have problems and probably require some assistance in terms of bowel management. And the last fun new therapeutic device we have is a sacral nerve stimulator. We only have one patient I've used this with in conjunction with our urologist colleagues. And we don't really know how this works, by the way, but we do know that the stimulator will stimulate the S2 branch from your sacrum. And we're not sure if it affects the afferent or the efferent limbs, but it does improve fecal continence. And it did not, this was not how it came out. It came out for urinary incontinence, but then everybody who got it, their pooping patterns improved. So this is, again, something, neuromodulation is big in medicine, and it's happening. This is a really busy slide. I don't intend for anybody to read all of it, but essentially, when you have somebody who's soiling, understand whether it's retentive or non-retentive. If you think it's retentive and you've done laxative therapy and they're still struggling, maybe they need an anorectal manometry, maybe they need further testing, maybe they need a transit study. If it's non-retentive, think of an MRI, think of spinal cord abnormalities, think of imaging their back. And obviously know when to refer to your neighborhood GI. So I think that's all I have, and probably just a couple of minutes to spare for questions. So thank you, and I will take any questions.
At what age do they do the anorectoplasty?
Anorectal manometry?
No, when they repair the
posterior sagittal anorectoplasty. I think that depends on the surgeon and the patient, right? Typically, like in a baby, until, they do that because they want to create an anal opening and have the child start stooling or learn stooling. So I would think when they're sort of age appropriate for that, yeah.
Usually they'll do it less than a year old. Again, they want to give the baby time to grow. They want to have enough anatomy, but they want to get this connected so they go kind of through the normal developmental process. So usually like 9 months or so is kind of the classic time. And it's different. If it's a low imperforate anus, they just kind of, again, that's more of an opening issue. They open it up. If it's a high imperforate anus, then it's a much more difficult surgery, so they'll delay that. And I just want to go back to another point that Shasta made several times. You have to do a rectal exam. And the kids under 2 in particular, particularly in girls, you need to look at the rectum. You need to make sure you don't have an anteriorly displaced anus, because that's going to make constipation worse and stooling harder. You have to treat that aggressively. The only way to know it is to look. And the babies with dyschezia, these moms that come and say, my baby's screaming, crying, passing stool. The other thing you need to make sure is that they don't have an anal stenosis that's not relaxing for them to stool properly. With anal stenosis, the way I always describe it for everybody is, Joe will remember this, going back to the days when we wore tube socks. The anal stenosis is a tight elastic band that you have to break. You need tube socks. Often you get one little piece of elastic, you just kind of snap your tube socks. You're going to feel a little kind of tight ring that's incredibly short as you're going through, feeling like you're going to pop an elastic or a string as your finger goes through. That is a little fibrotic ring, and it doesn't relax. So the baby's pushing, trying to get stool through a sphincter that's really not relaxing properly, and you've got to dilate that. I typically do a gentle exam, and if I really feel like I'm going for a ring, I send them to the surgeons, and they'll feel again, and they'll dilate the way they feel appropriate. But you won't know about it if you didn't stick a finger in there, and you won't be able to, really have a sense of an anal ring if you haven't done a fair number of baby visual exams to know that a baby rectum is pretty tight. You have to be gentle, and you lube up well, and you just insert slowly and let the anus relax and accommodate around your finger. And with the stenosis, it never relaxes and accommodates, and you'll feel the ring. If you don't feel for it, you'll never know.
I've done rectal exams before and didn't feel rings with a lubricated cube. Obviously, that's completely the sensation, but I guess it is safe to do rectal exams and new rings with you.
Especially with your fingers, Desi. Especially with your fingers.
Well, my finger, of course, but my fingers are.
No, it's safe. It is safe. It's safe to do. You just have to know how to do it. And the thing is, it's never fun. It's always nerve-wracking when you're doing it with the baby, but you got to get comfortable is the point, right? To know normal from abnormal, if you never know what normal feels like, you'll never know what abnormal feels like. Very good. Yes?
What's the best way to treat a child who has a revision? How do you address the pain and irritation and then, of course, the behavioral issues that could follow?
Right. So a fissure, a true fissure, with rectal bleeding and stuff probably requires, you have to, why is the fissure happening? Because it's an area of weakness. The tissue is ripped, there's probably exposed nerve endings causing pain, bleeding, whatnot. So number one, you have to make sure that that sphincter complex is not over stretching every time, so stool softener, so the poops really have to get runny almost, so it's not re-tearing every time they poop, because as long as they're having very formed stool, it'll just keep re-tearing and become chronic. And then you can always use like a steroid cream or something, like just locally in that area to help it heal. But if you don't do a stool softener, it will keep re-tearing and it won't heal all the way. So sometimes, the Anusol creams and whatnot, or a lower strength, just hydrocortisone, can help with that. Sometimes those tuck wipes, might help with that. And remember that they have to sort of unlearn the behavior too, because then it just also becomes behavioral, right? All right, guys, thank you very much.